The following program is brought to you by Winthrop University Hospital. It's the weekend. Be good to yourself. It's Katz's Corner with Dr. Aaron Katz, where you can get simple, straightforward answers to your questions about health. From diet and supplements to lifestyle changes. To reach Dr. Katz, call 800-848-WABC. Now, live on 77 WABC, the chairman of urology at Winthrop University Hospital in New York. Here is Dr. Aaron Katz.
Good morning, everyone. Welcome to Katz's Corner. So glad you could join me this morning. I have a wonderful show for you today. And if you'd like to reach us, me and my guest, the number is easy. It's 800-848-WABC. That's 1-800-848-9222. This morning, we will be focusing on a topic that is very timely, one that may affect many men out there, and their spouses for a number of different conditions. And we'll be talking about robotic surgery. I would say it's the new form of surgery because a lot of the surgeries are done robotically these days. And to help us with the discussion, I've asked a wonderful expert in urology and robotic surgery, Dr. Jamal. Dr. Jamal, I've known for many years now. He is a assistant professor of urology at Stony Brook and attending urologist at Winthrop. And he is a member of the Advanced Urology Centers of New York. Good morning, Joe. How are you?
Good morning, Aaron. I'm great. How are you?
Okay, great. Thank you. Thanks for coming on the show. I really appreciate that. I'd like to ask you to start out, just to help our listeners understand, what are we talking about when we use the term, he's going to have robotic surgery? What does that actually mean?
Robotics is a platform for us, for the surgeon to use. Essentially, it is just a tool. So when I talk to patients in the office, one of the analogies I'll use is imagine using a handheld screwdriver versus a powered screwdriver. The difference is that the tool helps the surgeon do the surgery. It doesn't actually do the surgery for us. And it's important because it doesn't actually take away from the importance of the experience of the surgeon necessarily. And it is a way of doing surgery that is laparoscopic, which is minimally invasive, but with more precision, more magnification of the areas, and therefore we can do more complex surgeries in smaller incisions, which helps patients recover.
And so you're using this, I know, for a lot of it I see on the schedule you have for prostate cancer, but you're also doing it for other areas in urology as well, right?
Yeah, I mean, one of the advantages of this is that robotic surgery, initially we were focusing on prostate surgery because of the small, narrow space that it needed to be done in, and the robotic technology allowed us to do that surgery more precisely. As we've gotten more comfort with the tools, the instruments, we've increased the complexity of the surgical procedures that we can do. So now we're doing reconstructive procedures, fistula procedures, cystectomy, which I do with Dr. Olson. All of these things are surgeries that are quite complex, take a long time, unfortunately, but we are improving the quality outcomes for the patient in most cases, just by having the smaller incisions and decreased bleeding.
Yeah, I mean, I've noticed that the patients leave the hospital pretty quickly with robotic surgery. So do you think at this point, in at least in the residency training and the patients that are coming in with prostate cancer or need their kidneys removed or their bladders removed, I mean, is open surgery now a thing of the past? I mean, is this something that's going to be like, wow, remember when we used to do those days with the scalpel? I mean, we don't, is that gone now?
I hope not.
Why? Maybe it should be.
Well, no. The reality is that there are cases that should not be done that way. Unfortunately, there are some patients that can't tolerate the increased pressures. There are patients where the space is going to be limited. There's previous scar tissue from there. You have to be able to do both options. And if you can't, then it's going to be a limitation for the patient. Sure, we want to try more and more surgeries this way, but you're going to still need the facility, the ability to do the cases open as well. So we don't want to pigeonhole ourselves too much, and so we still do some cases that require it in an open format.
Yeah, so what you're saying is that when you go to a robotic surgeon, and this is another question I wanted to ask you, put yourself in the patient's shoes for a moment. So you're going into a surgeon. I mean, what would you ask? Sometimes it's uncomfortable for patients to ask questions to the surgeon to get a sense of how good they are. But what would you recommend our listeners to ask someone like yourself, so that they are seeing somebody like yourself that has the experience to know when to do robotics or when to do open and how to do these things proficiently? Because as you mentioned earlier, it's not the robot, it's really the surgeon that's using the robot to help them, correct?
Correct.
Yeah.
I mean, I think it's very important that patients still have a level of trust with their patients. Mm-hmm. The patients have a level of trust with their physicians. They really have to have an open dialogue and go into these surgeries confidently. I'm pretty candid with people when I speak to them, tell them all the risks, and some of them are not easy to stomach when you talk about it. I'm fortunate in that I'm part of the Advanced Urology Center of New York in the Division of Integrated Medical Professionals, and we're the largest urology group practice in the United States. And we have partners we have 100 urologists in 45 locations between Nassau, Suffolk, Queens, the Bronx, Westchester, and Rockland. And there's a few surgeons who are doing a lot of these surgeries. And it's beneficial to the patient because we refer patients internally or sometimes outside, depending on the situation. But we refer patients to experts so that we can improve the outcome for the patient. So when a patient comes to me, I'm in the advantageous position of saying, of being in a position where I am already referred the patient as an expert, because the patients will know that they're in the right place. And what the patient needs to ask from their perspective is, how often are these surgeries done? How comfortable are you? What happens to me after the surgery? Those are the big things that patients really need to focus on. Sometimes they get into the weeds with some of the nitty-gritty, but being a tertiary type surgeon, a surgeon who does these all the time, is what patients are really looking for. You don't want somebody who does this once or twice a year.
So they should be doing them, regularly every week. 3, 4, maybe 5 cases a week. Is that reasonable to ask?
That's quite reasonable. I mean, there are certain situations, reconstructive cases, that are going to be less frequent. And so it may not necessarily be quite that often for the exact specific surgery, but you're going to want somebody who has experience.
Sure.
And all of it lends itself to the next case that you're going to do. Even though you do 100 nephrectomies and partial nephrectomies, it will help you when you do something called a pyeloplasty, a reconstructive case.
If you're just waking up in the morning, it's Katz's Corner here on WABC Radio. We're talking with Dr. Joe Jamal, who is one of our experts in robotic surgery at Winthrop University Hospital. And as he mentioned, he is a member of the Advanced Urology Centers of New York. If you want to reach Dr. Jamal, by the way, the number is, it's pretty easy. It's 844-DR, like Doctor, Urology, 844-DR, and that's, you have to write DR in the phone, and then urology, or the number is 844-378-7656. So I'm very interested about how, it's difficult these days. I'm sure you struggle as well, because we see so many different patients who have prostate cancer. And we'll just focus on this for a minute, Joe, about, their PSA, their Gleason, their age, their MRI. I mean, there's so many factors now that go into making a decision about, A, should a patient have treatment at all, and then B, is radiation the right way, is surgery the right way? And of course, this takes a lot of time in the office, and I'm asking a lot of you, I know, but if you could just give us a few thoughts in your mind as to who you feel is really the best candidate for this type of robotic surgery.
Well, two parts to the question. I think the
Right.
first part is, what is the patient perspective? What do they need to do or feel when they go in?
Right.
I think that patients really need to make sure that they're just gathering information in the beginning. Most patients are not in an emergency. They do not have to make a decision right away, and they will be okay if they're coming to sit with me to decide between surgery or radiation or observation, something called active surveillance. So we want the patient to be confident, or as a patient, I want them to be confident in the process, in terms of not being sold certainly, into one option. There are people out there that will, try to pigeonhole you as a patient into one option, but the truth is that patients really have the power in this scenario sometimes. However, during this conversation with all of the physicians they should meet, and they should all meet with their regular doctor who did the biopsy, with a surgeon, and with a radiation doctor as well. And during the process, they should just be gathering the information to help make the best decision for them. In terms of the second part, who is the best candidate for surgery? Typically, we want to do surgery on patients with a little bit more advanced cancer. If there's a small amount of disease, we can do active surveillance. That's proven to be quite safe, to watch this cancer and see how it changes, if at all. So patients who can tolerate the procedure, who are a little bit younger, and patients who have a slightly more aggressive cancer are typically the ideal candidates for surgery. But that, as you know, as we've discussed in our tumor board conferences, these indications are expanding a little bit as well. So it is important that we have the discussion candidly with patients to make them understand that all the nuances of this, because unfortunately, as we both know, it's not really very straightforward.
No, you're absolutely right, and it is a difficult discussion, and because, there's a lot of information out there on the internet. Some of it is right, some of it's not. Some patients come in with preconceived notions about things, and I think one of the things that's always in the back of the mind of the patient is, what if the cancer comes back? What if I have recurrence? Because no treatment is 100% curable, although I think with robotic surgery, I think it's very close to 100%, especially if you have someone that has, the PSA is under 10. Let's say they have even if they have a Gleason 7, and the MRI looks pretty good, and there's a few cores. Those rates of cure are very high. But patients always are concerned, especially a young gentleman, let's say in his 50s, if he has radiation, then what if it were to come back? And I think the treatment options may be a little bit more limited. What are your thoughts there if somebody were to have radiation? And certainly you and I, we both refer a lot of patients for radiation, and it's a reasonable approach. But what about in the younger patient, in the early 50s, and it comes back maybe in 5 or 10 years and he's only 60? Can you still do robotic surgery there?
Well, you can do it. There's a number of analogies that we use that indicate how much more difficult it is. So removing the prostate at that point is certainly possible. The worry is that there's a little bit more increased risk of complications both during and after the surgery, because the radiation has changed the tissue in the area and almost fused the tissue together, so that when we remove the prostate and put things back together, certainly it's doable, but patient quality of life issues can pervade afterwards, such as increasing risk of urinary leakage. We do this all the time, unfortunately, during cystectomy procedures. A number of patients have their bladder removed by me, and when they have a history of prostate cancer and they have had a history of radiation, it's the same thing. We're removing the prostate along with the bladder, and it goes quite well. I think better in some ways than the few open ones that we've done. And the concern, however, really being the quality of life outcomes afterwards. So for those patients who get radiation, I send them to you afterwards if they have a local recurrence, because their best option, if it's a local recurrence only, is to have cryotherapy of their prostate.
Sure. Yeah, you're right. I mean, the options are limited, but still there are good options for these patients. We're talking with Dr. Joe Jamal. If you'd like to reach us, the lines are open at 1-800-848-WABC. That's 1-800-848-9222. If you want to give us your thoughts or experiences or have a question for Dr. Jamal about robotic surgery. We have a few emails. I'm going to get to them in a few moments. I just want to ask you, Dr. Jamal, you mentioned something about, of quality of life, and, this is obviously of major concern. You mentioned that patients can have urinary leakage or erectile dysfunction. Are these things common in your practice and ways to prevent it? And tell us about ways to treat it for those patients that develop those situations.
Yeah, unfortunately, with prostate cancer surgery, there are going to be issues afterwards, and I tell everybody up front because I want them to know what to expect. So for these patients that are going into surgery, I have them start doing Kegel exercises to improve their muscle tone of the sphincter that helps control their urine. During the surgery, we're changing the anatomy. We're removing a gland that has been there for many, many years, and so the body has to adjust to it. So for those patients, during the operation, we do certain things to fix the urethra, to bring the bladder back together so that there's less tension on it, to maximize the length of the urethra, things that have been shown in various studies to improve the recovery of the functions that we worry about, specifically urine control and erectile function. I've been using some graft material, something called AmnioFix. We've been placing it on the nerve sparing, on the nerve bundles on both sides, and sometimes even around the urethra. This helps to reduce the inflammation and promote ingrowth of healthy tissue for afterwards. And then after the surgery, I tell everybody, listen, expect that you're going to leak in the beginning. There's new anatomy. There is a new way for your body to function, and it's going to take some time to heal. And I think having patients understand the risk up front makes it so that they're not surprised by it afterwards. And it will get better in almost everybody. And everybody it's going to improve. In the vast majority of them, they're going to be pad-free within a few months.
Yeah, so you may need a few pads, and then you'll be free. And I like this Kegel exercise approach. I always think that that's important, especially something that patients can feel that they can take control of, and they can do this on their own at home. And then, of course, the sexual function. And I know that this is fascinating. What you're doing now is you're able to spare and bring in some healthy tissue and things that will promote healthy tissue and reduce inflammation, which clearly has been in the past, at least with open surgery, a big problem. But now with robotics, you can, as you said, you can magnify the view of these very tiny little cables that run right along. I don't know why God made it that way. I mean, why did it have to be so difficult, right? I mean, why couldn't we just, right?
Agreed. Yeah. No, when I talk to patients and tell them.
Why is that?
We were taking out their gallbladder, their appendix. It'd be a 20-minute procedure. Unfortunately, these are much more complicated. The prostate's just in a tough spot down there.
And that's exactly why you need to go to someone like yourself that's an expert, that does a lot, that's fellowship trained in this. And I know that you do a lot of teaching of the residents at our medical center at Winthrop. And I think it's fascinating that we can now take the skill set of the young surgeons and take them from the open to the robotic and improve the outcomes of our patients, because the patients, from what I could see, I mean, how often do you ever transfuse a patient anymore? I mean, that's rare, right?
It's about 1% of the
That's
time.
not, I mean, we used to...
It's actually a little bit less.
We used to have patients donate 2 or 3 pints of blood, and then we would give them back that blood plus additional blood. Now it's rare to ever do that. And the patients leave the hospital in a day or two, for the most part, right?
Mm-hmm. That's true.
Yeah, I mean, so I think it comes down, as you said, to proper patient selection, and we are improving the outcomes of the patients and getting them back to work. Let me ask you, if you have a young gentleman in their 50s, early 60s, they're working, how long can they expect to be out of work for after robotic surgery?
Sure. It depends really on the type of work that they're doing. If they can do most of it in a managerial role, sitting at a computer, within less than 2 weeks, they can get back to work. If they have more manual labor, they're on their feet all day, 4 to 8 weeks, really depending on the patient, depending on the level of physicality that they need to do, or if they can go back to a part-time situation. So typically between 2 weeks for the more sedentary type jobs and 4 to 6 weeks for the more active ones.
You know, Dr. Jamal, I've seen a few patients lately that have asked me about testosterone replacement after surgery or after radiation. And, you know, I'm sure you see these gentlemen as well. Their testosterone is low. They need testosterone. But, of course, someone has prostate cancer, and you're concerned about giving them back testosterone. I thought that maybe one of the great advantages of taking out the prostate is that they're cured. Their PSA should be 0. And if it is, and it looks like it's all what we call organ confined, which means that the cancer is out, that they could go back on testosterone fairly quickly. What do you agree with that? What are your thoughts on that?
Well, you know, it's obviously a controversial topic. It's intuitively it's a little tough initially to think about giving patients back testosterone when we know that testosterone can exacerbate prostate cancer. For patients who I do surgery on and they're looking for testosterone afterwards, I typically make sure that they're cancer-free for 2 years, and then at that point we open up the conversation for it.
Really, 2 years? I mean, but even if they have, you know, you take out their prostate and, you know, we discuss this in our tumor boards and we look at their pathology and it looks like it's all out. Margins are clear. PSA is 0. Would you still say you still feel comfortable with the 2-year mark?
You know, I'm very conservative.
You are, yeah. I hear that,
quite
yeah.
Conservative, unfortunately,
yeah.
and it's a conversation that we have.
Yeah.
A lot of the patients actually end up going back to their primary urologist afterwards, and they can have a different conversation with them. But I'm just cautious.
Sure, let them deal with it, right?
Well, no, not quite. It's that you
right.
know, there are people who have different comfort levels with these things.
Sure. Yeah.
As the cancer surgeon, I really want to make sure that we do the best oncology for them.
Yes, and you do. Yeah, you're absolutely right.
And I have seen 2 patients in the past 5 years that have had negative margins and then a PSA rise, usually within the first 2 years afterwards. So you know, it's something that we have to be cautious with, regardless.
No, absolutely right. Yeah. Cancer is the most important factor here. And, of course, then, you know, we want to make sure they have an excellent quality of life. And as you mentioned,
Absolutely.
We can get them back into work within a couple of weeks, which is phenomenal, and then have them urinary and sexual function as normal. An email just came in, which is right on the track with what you were just saying. It says, Dr. Jamal, I had a radical prostatectomy 5 years ago, and PSA was 0. Now, last time I checked, it was 0.15. Can you explain this? Is this normal? Now, obviously, we don't have his reports or his pathology and things like that, but is that normal to have a PSA of 0.15 5 years after surgery?
Well, 5 years later, it certainly is a possibility that some normal glands were left in the area of the prostate, typically near the apex of the urethra, sometimes at the level of the bladder. Basically, my point is that not to lose hope at this point, just because the number went up very, very slightly, that sometimes in the process of trying to conserve as much of the tissue as we can, conserve the nerves, conserve the urethral length, and the bladder neck in certain situations, there can be a few rogue normal prostate cells that grow. And the number can very gradually rise. That being said, I would have him start checking his PSA again now, a little bit more frequently, to see what his doubling time is, and to make sure that this really is something that appears benign and isn't increasing too quickly. And if it does, we can always get an MRI and see if there's any enhancing tissue in the area, or just follow the trend on the doubling time of the PSA.
Yeah, I think that's very wise advice. Seeing these patients back now, Dr. Jamal, and you've been doing these surgeries for a number of years, Overall, just give us an idea about the patient satisfaction. Do you think that you're seeing these patients back and their PSAs are 0, which is much lower than you're going to get after radiation, I would think, and they don't have to be on hormones, and hopefully they need additional treatment. Are the overall patients that you see, are they satisfied with the approach that they took with having the prostate removed?
I would say the vast majority of them are. I think one of the important things that I tell patients is that their expectation has to be appropriate. We are doing major surgery. We are removing a gland, a piece of the anatomy, and the primary focus is typically, in almost all of these cases, is reducing the cancer. The secondary endpoint is urinary control, and tertiary is erectile function. The vast majority of patients do have good outcomes with all of these. However, their expectations have to be moderated a little bit and understand that things are not going to be perfect, especially in the beginning, but in the end, we have to put things into perspective. And once we get that information transmitted to patients, I think the vast majority of patients are in a good outcome and happy with their outcomes.
Realistic expectations. I think you're absolutely right. Let the patients know that there's going to be a time of healing. There could be a time of healing. You said that maybe they would need a pad in the underwear. Maybe they would need some medication. Do you use medications to help with the erections, the Cialis, Viagra, Levitra, things like that?
Yeah, I've used medication for penile rehab in the first couple of months. That's controversial, as you know. But I think that any promotion of blood flow into the penis and nerves is going to be beneficial to patients in the short term and in the long term. I have patients do manipulate themselves, just try to achieve orgasm 2 to 3 times a week, starting 2 weeks after the surgery, because it's all going to promote blood flow to the penis. The more you can prevent the fibrosis that occurs with inactivity, the better your outcome is going to be in the end, and the more comfortable they're going to be with the weaker erection in the beginning, and they're going to see that it improves. If you don't use it, you lose it type approach for that. And I tell everybody, you're probably, you're going to use medications in the beginning. You may need to use it long term as well. Most patients will, and it'll benefit their erection. They don't need to, many of them, but when they use it, it augments their erection.
And I think that's why you have high patient satisfaction, Dr. Jamal. You're very realistic with the patient. You choose the patients appropriately. And I know sometimes you do several of these in a day, so you're able to do them quickly, which is, something that obviously is of concern to patients. Less anesthesia time, less hospital stay, less blood loss, and overall improved outcomes. I want to thank you again for coming on the show. It's Dr. Joe Jamal. If you'd like an appointment with Dr. Jamal, you can call 844-DR-Urology, or the number is 844-378-7656. That's Dr. Joe Jamal, attending urologist at Winthrop University Hospital and also member of the Advanced Urology Centers of New York. Thanks so much, Dr. Joe, Dr. Jamal, for coming on this morning.
My pleasure, Aaron. Thank you.
I really appreciate it. You were very informative. We'll have you on again real soon. Well, that's the end of the show, everyone. I want to remind you that we do have the Men's Health Seminar this year. June 18th, people are signing up. You and your loved ones are invited to attend the seminar. You'll hear all about robotic surgery, testosterone replacement, and BPH, sexual dysfunction, and the management of rising PSAs and advanced disease. So please, come on to the website and register. It's easy. menshealthseminar.com. That's menshealthseminar.com, or you can give us a call at 516-663-9615. Thanks again, Dr. Joe, for coming on Katz's Corner this morning. The podcasts are always up at winthrop.urology.com or on the WABC radio website. Have a wonderful day, everyone. Tune in every Sunday. This is Dr. Aaron Katz.